And then dopamine agonists are another form of drug that stimulate dopamine receptors, but don't do it quite as well as the levodopa or the dopamine itself. And those drugs are very good for kind of middle Parkinson's. Sometimes we use them along with levodopa because they tend to last longer, but they will never be as good as dopamine itself. Yes?
What is an agonist?
An agonist means something that has the same effect on a receptor in the brain as the drug that was made by the brain to go there. So an agonist means if you have something that stimulates the dopamine receptor, it has the same effect that dopamine would.
A substitute?
Pardon me?
A substitute?
Kind of a substitute.
Thank you.
Sure. So these drugs have a huge slew of potential side effects, which I will talk about. So for that reason, we start with a tiny, tiny dose and we gradually increase these medicines. And the side effects can include lightheadedness, dizziness, daytime sleepiness, sleep episodes while driving. And then some people will have compulsive behaviors such as internet shopping addictions, gambling, hypersexuality, excessive eating, and then something else which we call hobbyism, where people can't stop doing a hobby. And you can imagine that it took us a while to figure this out, because when I give you a drug and you go home and throw up, you say, oh, it's that drug she gave me. But if I give you a drug and you go home and say, honey, let's go to the casino tonight, and tomorrow night, and the next night, and then let's buy some lottery tickets on the way home, you don't necessarily think, I bet this is that pill she gave me. Because you think, I've just developed a huge character flaw, right? So it took us a while to figure out, A, that this was a drug side effect, and B, that it was a relatively common one. The studies have got somewhere between, depending on how you ask the question and whether you had something going on before, probably between 5 to 17% of people taking these drugs can have some kind of compulsive behavior. Yes?
Why would you prescribe them? It sounds like the downside is bigger than the upside.
Why would you prescribe these drugs? They're terrible. No. First of all, not everybody has these side effects. And second of all, sometimes these drugs enable us to put off using levodopa for a year or two, or sometimes more. And these drugs don't tend to, by themselves, cause the dyskinesia, the involuntary movements. So sometimes it's worth the trade-off, because then if you're not having these side effects, you can put off using levodopa for a few years. Is there another question back there?
What happens if you throw alcohol into the mess?
What happens if you throw alcohol? That's a loaded question. Generally, I don't advocate people washing down these drugs with alcohol, but we live in the middle of wine country, so I do always get asked if, can I have a glass of wine with dinner? For most people, the answer is yes, unless you have a particular issue yourself with alcohol and should not be drinking it. And then I had a patient ask me if they could have a glass of wine with dinner, and I went through my usual, yes, as long as you sip it with food, don't take it on an empty stomach, drink a glass of water in between, blah, blah, blah. And then the person said, but it makes me feel terrible the next day. And I said, well, then don't do it. So, you have to listen to your body. So usually it's okay to have a little bit of alcohol with food. Don't ever do it on an empty stomach, because it goes right to your brain. And you also have to remember that the brain of a 70-year-old does not have the same alcohol tolerance that you had when you were 30, and certainly not that you had when you were 20. So you have to cut back on the amount that you would drink, and use some cautions like that. But just because you have Parkinson's does not absolutely mean you should not ever again have any alcohol. It's the same thing with coffee. Some people say, oh, I used to drink coffee, but once I was diagnosed with Parkinson's, I quit drinking coffee. Well, that's not going to happen to me, I can tell you that right now. And there's also some evidence that caffeine may have a little bit of neuroprotective effect. So don't drink it in the afternoon, don't drink it near bedtime if you're having sleep trouble, but you don't have to give up coffee just because you have Parkinson's disease.
So if the caffeine they think might have some sort of a protective effect, then if I use the coffee, I should not use the non-caffeine,
You should avoid decaf. Well, it depends on the person. That probably is not true for everybody, the neuroprotective effect. Plus, if you've already got Parkinson's, we don't know what effect it has in that situation. And again, sometimes people, it's more common that I hear about people having sleep trouble than just about anything else with Parkinson's. So you obviously don't want to be drinking caffeinated coffee all day long just because it may or may not have a neuroprotective
I just
effect.
meant 1 cup in the morning.
But then people say, well, what if chocolate keeps me awake? Does that mean I shouldn't have chocolate? And I would never tell people to not have chocolate because it's good for you. And especially dark chocolate has antioxidants. So if it keeps you awake, I tell people to have it in the morning. I can't have coffee ice cream at night because that keeps me awake. So the rare occasions when I have coffee ice cream, I would have it for breakfast, which I know sounds really strange. But, you don't want to give everything up. You don't want to give everything up, right? You have to be careful about how you use it. All right, so the dopamine agonists that are currently available are pramipexole, which is also, the brand name was Mirapex, ropinirole, the brand name was Requip, and now we have rotigotine, which is Nupro back on the market, and that's the patch, the dopamine agonist patch. Is everybody familiar with that? So this is the only patch of a Parkinson's agent. And people come in and say, oh good, does that mean I can quit taking my levodopa every 2 hours? Well, no, it doesn't, because again, it's a dopamine agonist, and they can be very good drugs, but they don't work as well as levodopa. So if you're on levodopa, unless something really new and dramatic happens, you'll always be on levodopa for, until we can figure out how to cure this. But the patch can be good for people as an add-on therapy or in early Parkinson's. Was that your question?
Yes.
Okay. Yes?
When you say early, middle, and late,
Uh-huh.
what exactly are those?
I'm referring mostly to the motor symptoms. So early means you're not on levodopa yet. Middle usually means you're on some amount of levodopa, and more advanced patients may have other issues like the motor fluctuations or dyskinesias, or maybe some cognitive impairment or other issues that we're dealing with. So it's kind of a rough category. People sometimes ask me about the staging with Parkinson's, 1, 2, 3, 4, 5. We use that as a research tool, but it's not really very helpful for patients because it refers only to motor symptoms, and it's basically whether you're having balance trouble or not. And so if you're not having balance trouble, but maybe you're having some memory problems or depression or dyskinesias, you could still be, a stage 2 and still find that it's really having significant impact on your quality of life. So I don't think it's that helpful for patients. Plus, patients get the idea that if I'm a stage 2 today, that means by, 2013 and a half, I'll be a stage 5. And it doesn't work like that. Everybody progresses at a different rate. Most people don't ever get to stage 4 and 5 because something else kills them. They don't live to be 120 or whatever. And then a lot of my patients are surprised that something else will kill them eventually. So they say, well, if my Parkinson's isn't going to kill me, what would? And I say, well, something, because everybody dies sooner or later. Like, what do people die of in your family? Oh, everybody in my family dies in their 50s of cancer. Well, then I wouldn't worry too much about the Parkinson's disease, right? So I'd be out there raising money to cure cancer. So, but I do have patients that are, except one guy. I've got one guy who's an undertaker, and he's one of the only ones that has not expressed any surprise that he's going to die someday. So, everybody else is a little flabbergasted by that. Yes?
When do you start the levodopa?
When do we start the levodopa? That's a really good question. We tend to first of all, a lot of times people come to me and they're already on levodopa. And in that case, I usually leave them on it because most people, by the time they're on it, they feel so much better that they wouldn't want to come off it anyway. But I usually start it when if somebody's starting to have dangerous symptoms like falling or trouble swallowing, they need to go on it right then. But in there's kind of a gray area where people say, well, I'm having trouble exercising, I can't really use my elliptical, or my tremor is so bothersome that I won't go out to eat. So it's when it really starts to interfere with your quality of life, and I can't treat that with other medicines, or the other medicines I can't get a high enough dose because of side effects or something like that. And I say, it's time for levodopa. And a lot of people fight me. I mean, they're dragging half their body around and they're miserable and they can't exercise, and I still have to practically hit them over the head to get them to take levodopa. And then they come back and say, oh, I feel so much better. And 3 people came up to me last week and said I looked younger. Why didn't we do this before? So just can't win.
Now, is that a form of levodopa?
Pardon me?
The Cinemet?
Cinemet is the short way of saying carbidopa levodopa. The reason it's called Cinemet is because levodopa originally was given by itself, and if levodopa converts to dopamine in the bloodstream, it makes you throw up. And then only a little bit of it goes into the brain. So the people who were in the early studies, and I've met a few of them, they said they were in the hospital getting this, and they were given huge doses, like 4,000 milligrams of levodopa and a kidney basin, because they threw up each and every time that they got the drug. And then they would throw up, and then a little bit of it would work its way into the brain and be converted to dopamine in the brain, and they would feel their symptoms be better. So I can't imagine any other drug you would take that would make you throw up every time and you'd still be willing to take it. But that's how much of a difference it made. Then they figured out if they put the carbidopa in there, it would keep the levodopa from being converted to dopamine in the bloodstream. And so, got an overtime here, getting there. So they put in carbidopa. That's why it's carbidopa levodopa. The carbidopa is just there to prevent the levodopa from being converted to dopamine in the bloodstream, because that's when it makes you nauseous. So they put the carbidopa in there. The carbidopa-levodopa combination was called Sinemet, meaning it's Latin for without emesis. Sin-emet. So you didn't throw up. So that's what. So the brand name drug was Sinemet, and it was brand name when I was trained. So I still will sometimes say Sinemet, even though it's more appropriate to say carbidopa-levodopa. Yes?
Once you're on the levodopa, so you're on it.
Once you're on the levodopa, you're generally on it forever because it works. And it usually works forever. So contrary to all this nonsense on the internet, where, it only works for 5. Did anyone ever see the Laugh-In show? Where the little guy on the tricycle would ride along and then he would suddenly flip over on the tricycle? Nobody ever saw that? I guess I'm getting older than my audience. Okay, some people saw. So I think people have this idea that the levodopa is going to work, and then, boop, you hit your 5 years and boom, you just keel over like the guy on the tricycle. So it's not like that. Levodopa generally helps some symptoms like tremor for most people, not everybody, stiffness, slowness of movement, some degree walking, penmanship, and so forth. And that usually will be true for the duration of the disease. The problem with Parkinson's is that other things may develop in the meantime that don't get better with levodopa. So that's kind of where it gets this idea that, it quits working. It doesn't quit working, because I'll say to people, well, you used to have a tremor. And they say, I don't have that anymore. You say, that's because you're taking the levodopa and it's still working. So that's where some of the confusion comes from. But basically, you're making less dopamine in your brain over time. You're having to take more. So they get the idea, I'm having to take more because it's not working. Well, that's not true. You're having to take more because it is working, right? So, and then other things like sometimes balance trouble will develop later in the disease, and that sometimes does not respond to levodopa. Maybe a whole different nucleus in the brain called the pedunculopontine nucleus. And that doesn't use dopamine as a neurotransmitter, so it doesn't get better when you take levodopa. So that's why levodopa's gotten this bad rap as this evil drug that quits working after 5 years, and the minute you start taking it, you start this imaginary clock, and it isn't like that. So, yes?
I just wanted to say that before my husband was diagnosed and didn't know what was going on, and when finally was given the levodopa, I described it as the awakening. It was like
So did you hear that? Her husband was like the awakening when he got the levodopa.
Yeah, he became an alive person.
Yes, so that's what it's like for people with the most common kind of Parkinson's. Not everybody has that kind of Parkinson's, so some people, I say, when you first got the levodopa, did it make a big difference? And they do what I call the scrunching up the face sign, which is they go, You have to stop and think about whether it helped. And when you have to stop and think about whether it helped, you probably have something you have a sort of a slightly atypical kind of Parkinson's that isn't just about dopamine. And so you get some benefit from it, but you don't get this like awakening kind of benefit that this lady's talking about. Yes?
Can you tell anything with the test on that balance issue that you're talking about that might not respond to levodopa, like for a CAT scan or anything?
No, you can't look, you can tell it a little bit on an autopsy after you die, but most of my patients aren't ready for that. So no, there's no way to tell. The way to tell is patients who, they say, sometimes my balance is poor, and I say, is it when your medicine's working or when the medicine wears off? And if they say, well, it just happens when the medicine wears off, then I say, that's probably a dopamine-mediated thing, and we can give your medication closer together. But if the medicine's working and all the other things, like the tremor's better and the handwriting's better and everything else is better, but you're still falling down, that's more difficult. In advanced Parkinson's, that kind of balance Is that the only thing for that is exercise and physical therapy and using a walker and whatever. Yes?
How long does it take for the levodopa to work?
How long does it take for the carbidopa
When you
levodopa
first
to work?
start taking
It depends on the patient. So there are two kinds of levodopa response, and one is called the short duration response and one is called the long duration response. And when I hear myself say something like that, it sounds to me like I'm pretending like we know everything about this, and we don't, right? But for the most part, some people will have an immediate response where in a few days they'll feel markedly better, and some people will gradually get better over a few weeks. And some people will think they didn't get any better, and then you wean it off to see what happens, and they say, oh my golly, I'm falling down now, it must have really been doing something. So there are all kinds of different for everybody. Yes?
I take 3 PD drugs every day, and usually I find that it works better on an empty, they all work better on an empty stomach. Is that
Medication does, she's saying her medicine works better on an empty stomach. Medicine in general tends to work better on an empty stomach because then you can get a higher concentration into your blood quicker. Otherwise it has to go through all that food. And with levodopa in particularly, it works better if you don't have a lot of protein in your system because the levodopa is competing with protein to get into the brain. However, in beginning Parkinson's, most people don't notice a particular change, and it's very common for levodopa to cause nausea in early Parkinson's. So I tell people to take it with food in the beginning to get them used to the idea. First of all, a lot of my patients have never taken meds in their life, and taking it 3 times a day is already a stretch for them, especially these Californians who don't want to take any meds and would rather smoke pot and sit on a mushroom somewhere. I'm telling you, I have patients like that. So to try to get them to take it 3 times a day, I'll tell them to take it with food to prevent nausea, get them used to the idea, and so forth. And then, if they start saying, sometimes my medicine works and sometimes it doesn't, then I say, you know, if you can tolerate it, why don't you try taking it like half an hour to an hour before you eat or an hour or 2 hours after you eat. Because you're right, it probably will work better. Whether it works a little bit better or a lot better depends on the patient. And whether they can even tolerate it without food in their stomach, because a lot of people just can't. Yes?
I have a question about Asla.
Aslect, yep.
Yeah. Can you take it with SSRIs?
Can you take Aslect with SSRIs? What a good question. Initially, it came out as a warning. So what happened when Aslect came on the market is that they got stuck with all the warnings for the MAO-A inhibitors, which was a very old-fashioned class of drugs that used to be used for psychiatry stuff years and years ago. And there were a very, very, very few reports with that drug and certain other medications that there was an interaction that could even be fatal. But that really, probably happened in 5 people at the most. So when the MAO-B inhibitors came out, they got stuck with the same labeling as the MAO-A inhibitors, even though we don't think that they cause the same response. But the FDA said to the company, you have to prove that you don't deserve this labeling. So they've had to do one study after another to try to get different things taken off, like the food and so forth. So what they've done with the antidepressants is, first of all, in their most recent batch of studies, they let people be in the studies on the top 6 most common antidepressants, but not Prozac or Nardil. So people on citalopram, escitalopram, paroxetine, amitriptyline, 2 more, sertraline, and there's one more that I'm blanking on. Pardon me? No, not phenylephrine. But anyway, they let people in the study on those antidepressants, and most of them are SSRIs. So that meant that they didn't see any contraindication. So I feel very comfortable using those drugs. Then the other thing they've done is they did a study where they took all these people who were on Aslect and followed them to see if they had any hospital admissions for interactions with antidepressants, and they haven't found any. So I don't think they've published the final findings, but we went through all of our patients with the fine-tooth comb. So there's not any indication that there's any problem. So they reduced it from a contraindication to a warning, meaning we can use them as long as we use the recommended doses. But the problem is that some of the pharmacies still have old computer software that'll spit out, oh, you can't take these drugs together. So we usually just fax them the things saying it's okay to take, and so I've got lots of patients. I've got hundreds and hundreds of patients on the combination. I've never, ever had a problem. The problem would be like a hypertensive crisis, and occasionally I'll get somebody whose blood pressure actually goes down because anything you do to augment dopamine can make your blood pressure go down. But I've never had anyone have even a hint of a hypertensive crisis on that combination. So, yes?
Does that include the flu and cold remedies?
The ones that always say, don't take if you have Parkinson's. Most of those are safe to take, but the ones that you can't take with Azilect are the ones that have dextromethorphan. So there's a list that your doctor probably has of drugs that's okay to take with Azilect. And then there's a teeny list, and that's a huge page of drugs. You can take OxyContin and morphine and just anything, you know. But on the back there's a list of what you should not take with Azilect, and that includes tramadol, Ultram, dextromethorphan, St. John's wort, cyclobenzaprine, and Demerol. So those are the only ones you absolutely can't take.
How about Novocaine?
I believe Novocaine's okay. Yeah. They used to say you couldn't take those, but that's another one that they've gotten taken off the labeling. So, yes, you had.
Do you think that Abilify and Zyprexa can cause Parkinson's at all?
Can Abilify and Zyprexa cause Parkinson's at all? That's a really good question. So there are drugs that are the so-called typical neuroleptics that are haloperidol and things like that, that block dopamine receptors. So they keep dopamine from getting to the receptors, and they can make you look Parkinsonian. Theoretically, if you take those drugs away, the Parkinsonism will go away, although there's some question as to whether they have long-term effects on those receptors. Then there's this class of so-called atypical drugs like Abilify and Risperdal and Zyprexa and blanking on the other one, that theoretically should be better for the dopamine receptor, but in my experience, they can all cause Parkinsonism temporarily. Abilify not as much. It can cause tremor though, but all the other ones also block dopamine receptors, and they can cause at least a temporary thing that looks like Parkinson's.
But it'll go away.
Theoretically, it will go away. Dopamine receptors are funny creatures that are always changing and being manipulated and so forth, so I would never say that they absolutely couldn't cause a permanent change.
How long would it take usually to see a change?
If it's going to clear up, it should clear up within, I'd say, 3 months. Yes?
What about tardive dyskinesia? That is a long-term effect.
Exactly. That's exactly. So tardive dyskinesia is an effect of those drugs on dopamine receptors that can cause an involuntary movement thing that could be there for a long time or maybe even forever. So that's why I say you can get changes with those drugs, long-term changes with dopamine receptors with those drugs. Most of the time, the tardive dyskinesia, tardive means late, and that means an ongoing issue, and they would say acute Parkinsonism, meaning Parkinson's that was just there for a little while. But the phrase tardive Parkinsonism has appeared in the literature a couple of times, so I don't know where that's going to go.